name is Regis. I'm one of the clinical pediatric pharmacists here at Denver Health. And today we're going to be doing a crash course in drawing up code dose epi for neonates, and maybe some things to think about or things that you can incorporate into your practice to get this done efficiently when you need to. And our goal here is to fix what's wrong. So if the patient needs epi, we just need to get it to them. And a lot of times people can get caught up in making sure that the dose is truly accurate dosing for the patient's weight. But I'm going to show you a way that you can still get those meds to the patients and reasonably fix what's wrong using an approach, which is the approach that I use. So when we are pulling up epi, we want code dose epi, which is the 0.1 milligram per ml. It'll come in a 10 ml carb eject like this. When we pull this carb eject out, you'll have two parts. You'll have the syringe and the barrel that the medication goes into. There's a needle underneath this green cap, and then a connector for IV site. Do not remove the green part on this because then you'll have an exposed needle. To put the carb eject together, you'll just take this yellow piece off of the actual epinephrine vial and then pop off the carb eject yellow piece. So yellow pieces we want to come off. You will screw in this epinephrine like so, and it should be stuck in there once you screw it in. And then you can remove just this yellow cap, and you will now have a nice connector for either a rapid fill, which is this ring, or you can use a two-way valve or a stopcock. And I'm going to show you both ways and benefits and maybe some cons to using one or the other. So if you need epinephrine, you put your carb eject together. It looks like so. We'll first do the stopcock. So I'm going to attach the stopcock, and there's three areas or three ports that the stopcock can attach to this epinephrine. We will unscrew the lure lock that will attach to our carb eject. There will be two of those. One of these goes to the IV line, and you won't be able to get a carb eject to attach, so make sure you're using the correct one. If this is all attached and is flowing the way that it should be, you will be able to take a syringe, and I'm going to use a 3 ml for right now because it's easy. And you can attach it to one side of your stopcock. Currently, this is in the off position. Where I attached my syringe, where I will be pulling my patient's dose, is in the off position. You will not be able to get med from here. You need to turn the stopcock in order to pull your dose. Now you'll get some bubbles and whatnot in there, so I just kind of leave it like this, and I just kind of do this, so I'm not flicking stuff all over. And then I can push back, and all this entire mechanism should move smoothly for you. I can pull my dose. Currently I'm going to pull 1 ml. Unscrew my syringe. Under best practice, I'm going to add a cap to that. Hopefully label this with whatever labels are available, and then give it to someone who is going to administer it. If you don't have labels available and you need to get meds, what I sometimes do is just take the syringe and I put it in the epinephrine box. And when I'm not using the epinephrine, I'll kind of place this all like so that I know what syringes are where. This is not best practice, but stuff comes up, and if you don't have labels available, this is one way that you can organize your doses so that you aren't giving the wrong med or something that isn't epinephrine when epinephrine is what you want. For dosing, there's a few different schematics that people use to dose epinephrine. There's two ways that we will be giving this. We'll either be giving it IV or we'll be giving it through ET tube. If we're using an ET tube, the dosing's super easy. If they're 1 kilo, you drop 1 mil. If they're 2 kilos, you drop 2 mils. 3 kilos, 3 mils, so on and so forth. We need to use higher volumes when we're using the ET route, so super easy. If our estimated weight's 2 kilos, drop 2 mils and just hand that syringe over. In my practice, something that I do is if I'm pulling up 1 syringe of epi, if we need 1 syringe, I'm pulling up 3 syringes. That frees up a lot of time. That's 6 minutes or cycles of CPR potentially, that I can be doing something else if we need something like bicarb. So if you draw 1, draw 3, they will be available when you need them, and you don't feel like you're being put on the spot. For IV doses, there is a range that we would use. It's 0.01 to 0.03 mg per kg per dose. What that equates to is 0.1 to 0.3 mils per kilo per dose, which can be a little confusing. If you're in the scenario where you need to draw something, remember 0.1 to 0.3 mils per kilo, because that will appropriately get you a dose that you can draw for that. I will use an example of 2 kilos because that seems easy. And initially when I am getting epinephrine, because I want to fix what's wrong, I'm going to be using usually 0.2 mils per kilo. So if I have an estimated 2 kilo kit, I'm going to be pulling up 0.4 mils of epinephrine in not 1, not 2, but 3 syringes of that. That should be enough of a dose. It's in between what our range would be for treatment. And if we want more later, I at least got 1 dose ready. So if the provider wants to go up to 0.3 mils per kilo, that's an easy adjustment to make. I have syringes that we can use in the meantime to make that adjustment. I also don't normally, and now I'm going to switch from this stopcock to this rapid fill. I prefer the rapid fill. It's super easy. It's less thinking. I can just connect it and then attach my syringe. In this example, I'm going to be drawing up doses for, let's say we have a kit that's 2.3 kilos. And I'm going to be doing 0.2 mils per kilo. So what I'm going to do, because it's easy for my eyes to see, and there's a lot going on, there's an emotionally charged situation, I don't think that the minute difference of a true weight-based dose of, I forget what I said my weight was, but we'll say 2.3 kilos, is going to be that different than if I'm just eyeballing a dose for 2 kilos. I can see that clearly on my syringe, and that's going to get me a dose faster that I can draw, cap, pull, and give to the team for administration. So I'm going to say 2.3. I think for intents and purposes, 0.4 is a good dose, which would be 2 kilos times my dose, dose, 0.2 mils per kilo. So I'm going to pull. I don't have to do anything with the stopcock. I'm going to pull my dose. These 1 ml syringes, sometimes you don't get as good of a suction, so it's harder to get the bubble out, which is why I initially used my 3 ml syringe. But I'm going to pull my 0.4 ml dose and cap it, label it or stick it in my box, and hand this to the team so that they can administer that. I'm going to pull another dose because I want to always have 3. And again, this is easy for me to see. I don't have to think about all these super small increments. That's why I don't like these 1 ml syringes. I guess maybe I can try this. There we go. So 0.4. And right there, we got a lot going on. We needed some doses of epi, and in a very short period of time. I was able to pull 2 appropriately dosed epinephrine syringes that we can give to this patient IV, just like that. It's really, don't overthink it. It can be much easier if you simplify what are we trying to fix and what is an appropriate way to get the medication to the patient. And I don't think fussing around with these super small increments is a way that I'm going to do that. I'm going to be dose rounding depending on the situation. Typically I will, because there's a lot going on and I don't want to get caught up making sure that my dose is so incredibly accurate that I'm missing something else, like I no longer have enough time to pull up bicarb or calcium or anything else that we need to get to that patient. And then that frees up a potential person to do other stuff, because now I have my epinephrine that is ready to be given in a pinch, and I have some time before I need more doses. That is it for this little tutorial on tips and tricks for drawing epinephrine doses. I hope you enjoyed.
Thank you, Regis.
You're most welcome.